talk about chronic stable angina. So what I will have here in this particular case scenario, the patient will come, for example, the patient will come with chest pain on exertion or motion, excruciating pain, Levine sign will be present. Patient puts his hand on the left side of his chest to show how much he is having the pain. Okay, along with that, palpitation, and this pain will be radiating pain. Along with that, palpitation will be there, diaphoresis, duration will be around for 10 minutes. It relieves on rest. Unlike unstable angina where pain doesn't relieve on rest, it relieves on rest, relieves on nitrates as well. Okay, now most of the cases this thing happen in morning because of vasoconstriction. Okay, so what will be, how my patient will look like? Here, as you can see, the question says that a 55-year-old male smoker presents with central chest pain on exertion. Okay, on exertion for 3 months, lasting for 3 to 5 minutes, less than 10 minutes. Our is 10 minutes around. Relieved by rest, so it is not unstable, it is a stable. This line says it's a stable angina. Released by rest or nitroglycerin, so it is a stable. Pain radiates to left arm and jaw, occurs predictably after walking 2 flights or stairs. ECG show no changes. Okay, what is the most appropriate initial pharmacological therapy for patient with chronic stable angina? So it is beta blocker. 2 more scenarios like that. 62-year-old female presents with type 2 diabetes and hypertension, experiences retrosternal chest discomfort while climbing stairs or carrying groceries that last for 4 to 6 minutes, under 10 minutes. Okay, and it resolves under rest, so it is stable angina. She denies pain at rest or nocturnal symptoms. Her treadmill stress test shows ST depression at stage 2 of Bruce protocol. Okay, it is also a stable angina. And next scenario, a 48-year-old male office worker with dyslipidemia reports tight chest pain on brisk walking uphill, reproducibly after 200 meters, accompanied by mild dyspnea and relieved by stopping. So relieved by rest, so it is stable angina. ECG is mostly normal in cases at rest, and risk stratification indicates intermediate pre-test probability. Okay, in both all these scenarios, it is chronic stable angina with predictable exertional triggers. due to coronary stenosis mostly. Unlike unstable angina, what happens in unstable angina is that in unstable angina we have symptoms are not worsening. Okay, in unstable angina symptoms worsen, prolong, and occur at rest. That's why it is more dangerous. So we initially will give beta blocker, antiplatelet, statin, and risk factor control. So let's see here. So now after we know it is in what happens in unstable angina, these two. Okay, in unstable angina these two are not relieved. Okay, and symptoms worsen over time. Okay, more dangerous. So after it is diagnosed stable or unstable, this identified. Now let's time to diagnosis. Okay, so for diagnosis, what we have in diagnosis, first thing we have obviously our ECG, and ECG is normal, ST is normal. In stress test, what we see in stress test, we see if it is symptomatic patients, they show ST depression. If I give nitroglycerin to them, sublingual nitroglycerin, then they get relief. And if I do ECG again, ST becomes normal. Okay, now what are the stress tests? The first stress test we have to do is treadmill test. Treadmill test is done. We use Bruce modified protocol. Okay, it is first done. If it is 75%, ideal is 85%, target 85 is target, that is ideal. 75% is stable angina. It is contraindicated in cases of unstable angina, mota लोकজন, morbid obesity. So for morbid obesity patient, what we do for these patients, we do stress echocardiography. If it is 80%, then it is diagnosis. Best is not best actually. Thallium scan. We can do thallium scan. There is also the most best is PET scan, because it can differentiate differentiate between uh, best test to identify the viability of myocardium. It differentiate a scar versus ischemic myocardium. Differentiate scar versus ischemia, ischemic myocardium. And now the gold standard is coronary angiography. Okay, now what is the treatment? Now the treatment, same as unstable angina, so I have some general management, and some specific management. In specific management, what we have, same as unstable angina, these things. So just write down. I have most important beta blocker, that is metoprolol. It decreases heart rate, so it is contraindicated when heart rate is already decreased. That means heart rate is below 60 per minute. Okay, this thing, beta blocker, it decreases the mortality, so it is important. Same as the other one, that is aspirin. Aspirin 75 mg/d or clotrimazole, clopidogrel 75 mg/d does the same thing. It also decreases mortality as well. Now we have other drugs as well, that is isomorphid mononitrate. For emergency use, we have sublingual nitroglycerin for emergency pain relief. Then obviously we have the other drugs as well, the new drugs like isosorbate mononitrate. New drugs are ranulazine, ivabradine, and nicorandil. Ivabradine inhibits the funny current. Now, after this specific management, medical management, if it is not changed, if there is no improvement, if failed, then we do surgical therapy, that is coronary angiography. After that, we do coronary angiography using Sildinger technique. We perforate the radial artery. Here is a picture of that. Where I make the picture, this is the picture, is like this, and this is going this, and this and this. So through the radial artery, my stunt comes like this. This is what? This is aortic sinus. Aortic sinus. The guide wire comes like this.